There she is. Hello, Alison.
Hi.
Good evening.
Hi.
Thank you so much for joining me on my live today. As I was saying, this is going to be an impromptu hopping on. So we'll just let a couple of people join us this evening. We'll do very quick introductions. So I'll say who I am for your followers who don't follow me. And then I'll let you do a little introduction of yourself, Alison. The topic of conversation this evening is because my socials have gone crazy. And the reason that they've gone, oh, it says it keeps breaking up. You're very clear to me. Am I okay to you?
Yep, perfect.
Perfect. So yeah, let us know if there's any issues with the tech side, because for me and Alison, everything looks perfectly fine from my end. But what we're going to be talking about, this new wonder drug, this amazing thing that's come out in the research papers today to say there's something that can prevent breast cancer for those in the moderate to high risk. And anastrozole is a medication that we all know as doctors, but today a lot of people might have just come across it for the first time because they've been reading the headlines and it's been everywhere. And I've definitely been seeing that in my surgery today. So we're going to be talking about breast cancer, prevention of breast cancer, and the new research as well. And I've got the incredible Dr. Alison who's joined me. So we'll just let a couple of people join us this evening, and hopefully we'll be here for a half an hour or so. And if there's any questions, I'll be picking those out. So for this evening, I'm going to be asking lots of questions, but it's for you as well on the platform. So without further ado, for those that don't follow me, hello, I'm Dr. Macbeth. I'm an NHS GP and I live and work in Buckinghamshire. I particularly work with sort of Black and Asian communities and ethnic minority communities as well. And when it comes to breast cancer, we know the statistics aren't so great in the Black and Asian communities. And I work a lot with the Supernova group as well, Supernova Asian Breast Cancer group as well. And really because we want to make sure that there's great evidence and also evidence-based information out there. And so that's why when something like this hits the headlines, I get a lot of Asian women who want to contact me for information. I've got the lovely Dr. Alison Macbeth, who's joined us this evening. She's a menopause specialist, but I'll let her introduce herself to you.
Hi, thanks so much for having me. Yes, so I'm Alison. I am a NHS breast surgery specialty doctor up in Scotland. I am a British Menopause Society accredited menopause specialist, and I'm also a women's health GP for NHS Highlands. And so I spend most of my time working in breast surgery clinic, seeing breast cancer patients, and I run the family history of breast cancer unit there. So I was having my breakfast this morning and just caught the headlines, and half of me thought, oh, fabulous, and half of me thought, oh dear.
So let's pick apart the headlines, because I got that this morning as well. And actually it was great. I felt really good reading the headline. You know, there's a medication, this tablet that's available right now, and it will reduce your risk of breast cancer, or be a preventative for breast cancer. And that is something that we're always looking for as NHS GPs, because you and I know a lot of our work is about preventative care. So anastrozole, which is a medication that we know because a lot of our patients use it as a treatment for breast cancer, is now going to be used as something that's going to be preventative, but it's not all what it seems. No. So I thought we'll pick apart and go beyond the headlines. Firstly, for those who don't know, let's start with the first thing. What is this drug? What is this that's out there at the moment that's available?
So it is basically, it's called anastrozole. It's an aromatase inhibitor, and aromatase inhibitors will only work for postmenopausal women, because what it doesn't stop your ovaries producing estrogen, so you have to be postmenopausal. The way it works is it basically stops the conversion of sex hormones, so androgens, mainly produced in the adrenal glands, and it stops them converting to estrogen, and that usually occurs in the fatty tissue. So that's why they're called aromatase inhibitors, because they stop the enzyme aromatase working. We have been using them for years and years and years for treatment for breast cancer. And so they did some trials that looked at, can they be used for what we call chemoprevention? We've been using tamoxifen for chemoprevention for women in high risk. And so it's nice that we've got something else that we can use as well.
So we need to understand, because this medication is treatment. It's about 1 milligrams
Yeah.
that we give on a daily dose, and it's usually for roughly 5 years after you've had treatment for breast cancer.
So yes, so if you're using it for breast cancer, yeah, you would use it. Well, it depends on the type of breast cancer, and it depends if you're using it with anything else. But if you're postmenopausal with breast cancer, you'll use it between 5 to 10 years,
5 to 10 years.
Depending on, as I say, how aggressive your cancer is.
And with this medication, at the moment they've trialed it as a preventative. And so that's the IBIS trial, IBIS trial number 2. And this is something that's been going, the trials have been very lengthy. It's been going on for quite a while. I've known about it because I was following this along going, this is amazing that this is something that's preventative. But when I work as a GP, my patients don't like aromatase inhibitors. They hate anastrozole.
Yeah. I was quite surprised when I read the wee snippet from the BBC News, because one of the people quoted stated, oh, this is something that is actually better tolerated than tamoxifen. I have to say, in my experience in breast clinic and as a menopause specialist and as a women's health GP, I've really met a woman that tolerates an aromatase inhibitor better than tamoxifen. Maybe they did in the trials, I don't know, but in real life, I was quite surprised when I read that. So the main side effects, I think it's actually important to kind of discuss. So the point of aromatase inhibitors is essentially to plummet your estrogen to negligible levels. So the way I usually describe it when I'm talking to women with breast cancer in breast surgery clinic is I'll say to them, look, when you're before the menopause, your estrogen's up here. After the menopause, naturally, your estrogen's kind of down here. With an aromatase inhibitor, your estrogen is literally on the floor. You've got a 100-year-old lady estrogen levels is essentially what you've got. And we know that the body's covered in estrogen receptors. We've got them literally everywhere: skin, hair, nails, brain, heart, bones, everywhere, vagina, bladder, everywhere. So we need estrogen. You know, we need estrogen as women, for our bodies to function. And aromatase inhibitors, if you have breast cancer, are thought to be a good thing to prevent recurrence. And that's what they do. They reduce risks of breast cancer recurrence. But for the rest of you, it's not such a good thing. And the main side effects of these medications are significant joint pains, joint stiffness, and yes, sometimes they get better over time. And if you leave it 6 to 12 months, sometimes they get better over time. But again, my experience, they actually often don't. And they often get worse and worse. And a significant genital urinary syndrome of menopause. In the old days, we used to call that atrophic vaginitis, which essentially means dried out old vagina. But we know it's so much more than that, and it is to do with the urethra, which is the tube that goes from the vagina into the bladder, and also the bladder neck and all your pelvic floor. So the estrogen the aromatase inhibitors, you know, no bones about it. They can often cause carnage down there and cause significant genital urinary syndrome, menopause. And it's really important that we're honest with women about the risks of taking this medication and the side effects.
So let's look at the trial, because I looked at the data from the trial, and it actually did say that some of the patients didn't actually get on well with anastrozole at all. In fact, 75% of women complained that they weren't liking it, but then they got over the side effects after 1 year use. And I just think that in reality, we're going to be those patients, you know, we're the GPs who are going to be struggling with this. And then also the fact that there's a risk of fractures with this. Now, we know that patients who go on anastrozole already, they have to have a DEXA scan, and then they have a DEXA scan 2 years later to make sure that they're not a high risk of sort of getting fractures. But the trial data didn't really comment on that much. It seemed to apply that we don't need to worry about fracture risks so much with this.
Yeah, and
if it's used as a preventative.
Yeah, and I actually wonder whether it's just because the follow-up's not been long enough.
Possibly, that's possibly the reason.
Yeah, I mean, I have to, be very honest. I've literally just got home from work and was frantically reading that wee link that you sent me before we joined up. So I haven't been over all the data in detail because literally been working all day. But I mean, what we could see is that I think what they said was, let me just get, I've written it down, no difference in death rate. So it reduces risk of breast cancer occurrence, but it doesn't reduce your risk of dying. And it said no excess fractures or heart disease, cardiovascular disease observed. Well, yes, that makes me think, okay, we've just not had long enough follow-up, because we know that one of the main risks of aromatase inhibitors is osteoporosis, and osteoporosis increases your risk of fractures. So, and then they also, I think, commented that there was no evidence of new late side effects, but that was it. I was like, well, what does that mean? What side effects? Because we know aromatase inhibitors cause significant side effects. If we look in the BNF, British National Formulary, so that's the kind of the drug Bible that everybody uses, the list of main side effects with aromatase inhibitors is your joint pains, your genital urinary syndrome of menopause, your mood, low mood, flushes, hair thinning, low libido, abdominal pain. I see this all the time in breast clinic. Women end up on colonoscopies, investigated for diarrhea and abdominal pain, headaches, nausea, skin rashes, increased cholesterol. So, there are side effects. So I don't understand what they mean by no evidence of new late side effects.
I think you're spot on. It's because they haven't got the long enough data yet to be able to say that. But the headline has come out to say that this is amazing. And in a way, we've got to say, yes, it is. But actually, it does come with some side effects as well. But also, we've got to also look back at the fact that it is for those postmenopausal women, so between the age of 45 to, say, 60, who are at high risk and moderate risk. The other thing I get, women are like, I don't know whether I'm moderate or high risks. So I thought maybe it'd be a good idea just to touch on that, on what puts you into the moderate category of risk of breast cancer.
Sure. So we know 1 in 7, 1 in 8 women will get breast cancer. And the way that they work out your kind of risks, your family history risk, is moderate risk is, so basically a normal risk is under 17% lifetime risk of developing breast cancer. The biggest risk of any cancer, including breast cancer, is age. So the older you get, the more at risk you're going to get. But normal risk is under 17%. Moderate risk means between 17 to 30% lifetime risk. High risk is between 30 to 40% lifetime risk. And very high risk, so that's like your gene positive, your BRCAs, is greater than 40%. And we work this out, well, we were having this discussion the other day about nice guidance or Scottish guidance. But essentially, if you've got a first degree relative diagnosed with breast cancer under the age of 40, so just one, that would put you at moderate risk. And then if you had 2 first degree or a first and second degree relative diagnosed with breast cancer under the age of 60 in Scotland, that would put you at moderate risk. In England, they say at any age. But again, we've got to remember, if your gran was 80 and your mum was 80, does that put you any higher risk? Different countries have got slightly different guidelines. High risk is if basically you've got a first degree relative with breast and ovarian cancer, or multiple family members with breast or ovarian cancer. If you've got a first degree relative with male breast cancer, they're going to be offered gene testing. So there's quite a few nuances about it, but essentially it's, if you are high risk, it seems to be that they've well, from the data I looked, it said high risk. You can correct me if I'm wrong. I couldn't see whether they commented on whether they'd given it to moderate risk women.
They gave it to high risk, but they said it's available for moderate to high risk patients. And I think that's really interesting, because it means that we have to firstly risk assess them, but then as doctors, when you're trying to counsel your patient whether this is something that they should be taking as a preventative treatment, you want to really give them quantifiable data to say, okay, how you'd have to take it for 5 years, because that's what the trial is saying. Yep. 1 milligram for 5 years. What are the chances that you'd reduce the rate of cancer? And the trial was it said, and correct me if I'm wrong, but it was, 1 milligram for 5 years to high risk women, and you need to give it to 29 women to reduce 1 case of breast cancer. And for someone who works in a breast cancer like yourself, sort of put those into context for our viewers, is that a significant dent in the numbers? Because that doesn't sound significant to me.
No, and I think it's really important to say that you may have a family history risk, so you can't do anything about your genetics. You can't do anything about the fact that you're female or how old you are, but you can do something about your modifiable risk factors. So even if you're at moderate or high risk of breast cancer, you can still reduce your risk of breast cancer by working on your modifiable risk factors. So you can't just look at the numbers, and yes, I agree with you. Those numbers to me aren't very meaningful, and actually aren't very high. But also, if you're taking something that's going to reduce your ability to work on your modifiable risk factors, so for my breast cancer patients on aromatase inhibitors, a lot of them can't exercise because they're so sore and stiff. So if you then can't exercise, you put weight on, and we know that exercise reduces your risk of breast cancer by so that's moderate to intense exercise, by up to 30%. So if you're taking something that's stopping you exercising, that's making you put weight on, that's causing you depression, so if you've got depression, you might go for your poorer lifestyle choices, hit the bottle, so that we've got to weigh all this into account, and it's not just about cold hard numbers.
So I obviously, as you said, you're having breakfast, read the headlines, and then I get into work, and like yourself, your phone's going off because patients are really keen, and it's breast cancer is such an emotive conversation, because some of my patients, their family members have had breast cancer. It's a horrific disease, depending on where you find it. It can be really traumatizing for families as well. The word cancer itself is still a taboo in amongst many cultural or marginalized groups who have very little understanding. They literally think it's a death sentence.
Yes.
And unfortunately, some of the headlines and from the papers were like, speak to your GP. And I was thinking, I have had no information. So for anybody watching this live, I would say, please don't contact your GP about this, because I've had no emails, and that's the 7th of October today, as of today, and I've been checking my emails all day from the powers that be that say, yes, as doctors, we should be prescribing it. So where should we even be thinking about preventative breast care health in the NHS?
So these women with high risk are going to be under breast units. They're going to be under family history of breast cancer units. So if you are at high risk of breast cancer, you're going to be having annual mammograms till you're 60, and then 18 monthly mammograms till you're 70. And these are in family history of breast cancer units. So nobody should have been saying to these women, go and see your GP. That's nonsense. What they should be doing is they'll be having annual reviews from their family history clinic. So they can either wait till their next appointment at family history, if it's going to be within the next few months, because there's no mad rush to start these medications, or they can contact the breast care nurse. So their breast care nurse is going to be the first port of call in their breast unit. As I say, I run the family history unit in my clinic, in my hospital, and I absolutely wouldn't expect GPs to be initiating or having that conversation about aromatase inhibitors. When I see my women on an annual basis for their annual reviews, I talk to them about, do you want tamoxifen? This can reduce your risk of breast cancer if you haven't had it, if you're high risk, but it doesn't reduce your risk of dying. And you have to counsel them because the numbers aren't very high. But I absolutely wouldn't expect a GP to be doing that counselling with tamoxifen, and so I absolutely wouldn't be expecting a GP to do the counselling with aromatase inhibitors. And also, as you say, if you've got breast cancer and we're sticking a woman on aromatase inhibitor, we do a baseline DEXA bone scan. And I don't know what the wait is like with you, but in Scotland, it's over a year wait for a DEXA
We've
bone
got a
scan.
similar wait.
Yeah, it's a
we've got a
nightmare.
similar
So again, we're going to think about, if we're putting these women on aromatase inhibitors, I couldn't see anything in the link you sent me about, okay, did these women have baseline DEXA bone scans?
Yeah.
And
They didn't declare that.
no, they didn't declare that. And then, so then how can they then say there was no excess fracture risk? You know, if we didn't have a baseline, so then we're clogging up the DEXA bone scans, maybe, for the women who really need it. So it's just all weighing up what's the right thing to do. But so for any woman who's in a family history clinic, I would say contact your family history unit and not your GP, because it's a discussion for your family history unit. And would be organising the DEXA bone scan.
And Dr. Sarah Ball, who's watching this live, actually has made a really good point. She says, while some clinicians join the dots and recognize side effects of aromatase inhibitors, I would suggest that most do experience side effects, but nobody realizes, either the patient or the clinician. And I think that's very true, because especially when you're taking something either as a treatment for breast cancer and then later on to stop reoccurrence, you don't join up the dots because you're just glad that your breast cancer has been treated. You're just getting over that survivor mentality. I've survived cancer. And so to put all the joints, the dots together to say my joint pain, my depression, my hot flushes, and vaginal atrophy, I tend to find in my clinics that patients will come maybe 5 years later, and their sex life is completely gone, their intimacy is gone, their vaginal atrophy or genitourinary syndrome, the menopause, is at severe stage.
Yeah, it's awful.
But then they go, because they've been so scared of taking estrogens. And so I will counsel them and say, actually, we could use intrarosa. That's very safe to do so. And the fear of just that is there. And I don't know how we get past that. I suppose it's education.
Yeah, I mean, even when women come to breast clinic, they're not joining the dots, and the clinicians are not joining the dots. I mean, I think the first thing is, with these aromatase inhibitors, if you've got high risk women, you've got to establish, are they postmenopausal first? Because they're not going to work if you're not postmenopausal. So you've got to establish, are they postmenopausal? Some of these women are on HRT, because HRT, having a high risk family history of breast cancer, is actually not a contraindication to HRT. It's weighing up those benefits. But if they are on HRT, then they'll need to stop it. And as you say about the vaginal estrogen, there's so much fear of vaginal estrogen in women with aromatase inhibitors. So is there going to be that fear if women are taking it for chemoprevention, for prophylaxis? I suspect there will be. And as I say, the issue with the DEXA bone scan, they need counselled about taking your vitamin D, your vaginal moisturisers. I mean, if anyone knows me, knows I'm absolutely passionate about genital urinary syndrome and menopause in breast cancer.
You're the queen.
Yes. And family history women, and every day I do battle, I think, to try and get women adequate treatment. I mean, so I really worry about that, and I think we've got to be really honest with women. And I hate hearing kind of these headlines going, it's well tolerated, it has very little side effects. Well, that's not my experience in breast unit, and I'm seeing it both from using it in breast cancer and as a menopause specialist. So I'm seeing two sides of the coin, so to speak. And we are causing significant issues with the vaginal atrophy, the recurrent urine infections, the risk of urosepsis. Every day I'm seeing women whose relationships have broken up because they can't be intimate, or it's too painful, or they can't exercise, they're putting on weight. And I think that we just have to be really honest about the side effects. If we had a man in front of us and said to him, look, we've got a medication that might prevent your risk of prostate cancer, But actually, you know what, it might cause atrophy of your penis and your testicles. So therefore, it's going to make it far too painful for you to have sex. But that's okay, because actually your libido is probably going to be rubbish, and your relationship might break up, and you probably put some weight on. Are they going
I
to
probably have
take
a fracture.
medication? They would look at us like we were bonkers, and we're going to say, and it won't stop you dying of your prostate cancer, but it might prevent some. I don't know how many men would take that, so I don't understand why it's okay to have this headline saying this is, and it is good that we've got something else for breast cancer prevention, but we have to be very honest about there are implications to this medication and there are risks to it, and it's not a 2-minute phone call to your GP. This is a full counselling by your breast unit.
Yeah, as much as both of you and I as clinicians can appreciate, it's nice to have one thing more in our basket to be able to say, look, for our high-risk patients, there is preventative. Yes, there is ways that we can go around it. A really good question from one of the viewers this evening saying, isn't it better to invest in sort of reducing the rate of obesity, which is a bigger risk of breast cancer?
Yes, I mean, where did I had my, oh, I put it somewhere, I don't know where I put it now. I had my wee infographic about kind of reducing risk of breast cancer. We know that exercise, you get 7 less breast cancers with moderate to intense exercise. You get 24 more breast cancers with obesity. But actually, these medications can make obesity worse and reduce your ability to exercise. And actually, we're going to get far more benefit, as your viewer says, that if we invest in sports programs and you know, healthy eating, you're going to get more benefit from risk reducing. So this is what I was saying, although you may have a family history and you can't do anything about genetics or your age or the fact you're female, what you can work on is lifestyle, and it's vital. And again, the other thing that worries me about these prophylactic medications, and it's a bit like, you know, people on statins, that sort of thing, is they pop a tablet and think, okay, that's all they have to do, but it's not. They have to work on their lifestyle as well.
Another really great question. Can you tell us, is tamoxifen already being offered in high-risk patients as a risk reducer? It's not. Is it? Or is there a trial going in?
Yeah, we offer it in our family history clinic. I have to say not many patients take it, because again, it's just basically you have to treat 1,000 women with tamoxifen for 5 years to prevent 18 breast cancers. And now of those women, 5, and in every 1,000 women, 5 might have a blood clot, 4 might have womb cancer, and 4 to 8 might have cataracts. So, you know, again, it is just being honest about the risks and the benefits, and you know, saying to the women, okay, well, you know, it reduces risk of breast cancer, but not death. And it's the same with the anastrozole. They said in 10-year follow-up, you got a 49% reduction in breast cancer cases with the aromatase inhibitor, and the largest reduction in the first 5 years. Well, yep, that's great. That's really good. And so it's great to have something else in our arsenal, but let's not forget our lifestyle. And let's not forget the risks. I have a hard enough time getting my breast cancer patients to stay on their aromatase inhibitors, and that's with breast cancer, and that is reducing the risk of breast cancer recurrence. So that's what caused my heart to sink this morning when I was having my breakfast. I thought, okay, this is good, but you know, we really just need to kind of think about the risks of using these as well as the benefits and the implications to things like waiting list for DEXA bone scans.
Like my colleague, Dr. Sarah, who we adore, both of us do, she's always a pragmatic, and she says, call me a cynic, but is this purely being rolled out as anastrozole is now off patent? Because that's the other argument I've heard this morning. It's cheap, it's out there, it's really cheap. And I remember that being an argument for statins as well. So it's a political point scoring exercise at the expense of women potentially suffering. And I think that's a really good point, because I always wonder why certain headlines are pushed, and it's usually because they've come off patent. And they now are saying this is the thing to do. And we saw that, didn't we? We saw that with atorvastatin, and everybody, you know, under the sun should be on statins. And I now take a really pragmatic role with my patients and really look at the risks and benefits. And some of them, I don't put them on it.
Yeah, yeah. I mean, I think we've just got to be honest, and it can be a difficult, uncomfortable conversation to have. Um, and if I have a woman in front of me who's really worried about her risk of breast cancer for whatever reason, but she's significantly obese, it's always a really, really difficult conversation to have. And you're like, well, okay, but actually your risk is your obesity, and no tablet is going to reduce that risk more than reducing your obesity. So it's having these uncomfortable conversations, and they're not a quick 2-minute conversation. And I felt really sorry for GPs across the UK today, because actually, it's not their conversation to have. It should be done in family history of breast cancer clinics. These women are under them. And yeah, I think there was no warning. I mean, it was the first I heard
Anything is the first I
warning.
heard this morning.
Yeah. So I'm thinking, oh, that might have been nice to know, because, you know, my family history clinic on Thursday, I'm sure I'll be getting lots of questions. Although actually, it's not licensed in Scotland yet, but we'll see.
Thank you. We've just come up to 6 o'clock, because I know how busy you are and everybody has got to get to dinner. Please leave questions at the end of this, because I will be posting this on our page. I'll make Dr. Alison a collaborator with me, so we'll try and answer them as much as possible, because this has opened up so many questions, and I'm so sorry I couldn't get to all of them on this live, and you've been so wonderfully interactive with us this evening. I'm sure that after this it might instigate another live, because as you've seen, Alison is very pragmatic and to the point, and I like that in a colleague. So thank you for...
far to the point.
No, it's wonderful. It's wonderful. It's what I need, because as GPs, it's suddenly like, well, go to the doctor. And I know what it's like, you know, being sometimes in the media, commenting on media headline pieces. And actually, we've not been told. So the miscommunication around this is just one of the factors which causes frustration. So I thought the best thing to do is to buddy up together and just all sing from the same hymn sheet and say, fundamentally, your lifestyle is going to be the biggest thing that we need to look at in regards to reducing your risk of breast cancer. But then there are these family clinics that we can give you options. And one of the options is, yeah, it's not going to be for everybody, but anastrozole is not without its risks. So thank you so much for your time this evening. Thank you for joining us, and I'll see you hopefully soon. Bye.
Thanks for having me. Bye.